Alrighty, we'll go ahead and get started now. I'm Brianna. Thanks everyone for joining us again. This is Decoding DX. We have an awesome case today with some amazing discussants. I'll have everyone introduce themselves here in a minute. We have Dr. Abebe is our expert discussant. If anyone isn't familiar with him, he is one of our attending physicians in the internal medicine department. He's absolutely incredible, one of the best attendings and the best teachers that I've ever had. So we're very honored to have him here. So he'll be our expert discussant, and then our student discussant is going to be Rachel Jenkins. She graciously volunteered to help us discuss and give the M3 kind of thought process. So I'll have you guys introduce yourself. Dr. Bebe, if you want to start real quick, and then Rachel, you can follow him.
All right, thank you for that flattering introduction. I would say this, I'm very passionate about medical education and especially medical students. I always tease my students and saying that you guys pay way too much money not to probe in and ask your attendings to do their best to teach you. You know, in all seriousness, I'm very passionate about education. I think the least we can do is share our knowledge and make you where you want to be and help you through mentoring, if you will. I'm a core faculty, and I've been a core faculty for the last 10 years. I look deceptively young, but you know, I guess you guys give me life. Let's put it this way.
Right, I can introduce myself. I'm Rachel Jenkins. I'm a third-year medical student. Just started this my first week of psych, so it's been exciting to get into that. Currently interested in rheumatology, but we'll see what happens.
Alrighty, thanks guys. So just a quick note from last week, we appreciated everyone that was here. We took a few different points of feedback, and we're going to kind of adjust how we do the format and layout this time. It's going to be a lot more kind of conversational and less structured. We're going to try to get to the treatment part because we feel like that's a little more high yield for this particular topic. So we'll spend a bit more time in that discussion. So it's going to be just kind of free. Again, I don't know is a badge of honor, not a badge of shame. So kudos to whoever says it first. That's the goal. With that, if anyone, no one has any other comments, we'll go ahead and get started with Ben with our case.
Sweet.
I am going to say real quick too, I'm going to be manning the chat and kind of like speaking up if anyone has anything that they add in from there. So if you have anything, feel free to put it in the chat and I can kind of interject your thoughts.
Yes, we encourage high activity in the chat. Please make it fun.
Sweet. Thanks for that, Kelsey. Can you hear me fine? Beautiful. So excited to be with you all. Just came out of a patient case that would be a great future one of these in a room here in our outpatient clinic, but that is not our patient today. So our setting is that you are working in an ED, and there's a very nice 64-year-old male who comes in with palpitations and vomiting. So go ahead and start formulating your differential. We're going to get to that really soon. I'm going to give you just a little bit of his history, and then we will start building a problem representation and grabbing a differential. So he recently was admitted to the hospital, and he has felt funny ever since he went home. Just yesterday, started developing some palpitations, nausea, and vomiting. He said that he hasn't eaten very much since he went home from the hospital 6 days ago, and he came in because his palpitations acutely got worse today. Vomited this morning, and then he received an enema in the ED, and he vomited again shortly afterwards. But he denies any fevers, any chills, any headache, any chest pain, any abdominal pain, and he denies any shortness of breath. So with that, let's go ahead and come up with a problem representation, and then we'll work briefly on a differential diagnosis for a patient with some of these complaints. So Rachel, can you go ahead and give us a first stab at a problem representation?
Yeah. So here we have a, didn't catch the age, was it 64?
64.
Okay, 64-year-old male presenting to the emergency department with palpitations and vomiting recently discharged from the hospital.
Very good. And so then what are some of the things on your differential?
So me?
Yeah.
Okay. Well, not knowing much, of course. I'm going to be concerned about cardiac. We want to take a look at electrolytes to see if there's any abnormal things causing some weird arrhythmias. Yeah, so probably arrhythmias. I'd be concerned, could ask about any psych history. That's what I'm on, so I'm thinking about anxiety. Yeah, those are two that come to mind.
Two great places to start. Any other differentials that folks have in their mind that they're thinking about? Put them in the group chat or chime in.
Dr. Abebe, what's the first things that come to your mind as far as, what would you want to make sure to rule out? Would you be worried about this patient if you were seeing them in the ED?
So very nice start, by the way, Rachel. So as you rightly started, I always think of primarily what could kill this patient versus the other. So we always think of cardiac, like you stated, and I want to make sure that this patient has any arrhythmia. Is this a supraventricular arrhythmia versus a ventricular arrhythmia? Majority of the time, this is going to end up being a supraventricular tachycardia, because if this is a ventricular tachycardia, the patient would be much more sicker and would not wait this long to be presenting. When we talk of supraventricular tachycardia, we'll think of those that are regular and irregular, and then we can go on the discussion on that end. One of the most common presentations as an arrhythmia from a cardiac origin is in patients who have mitral valve prolapse. I had a patient who doesn't have any other symptoms, came in with just severe nausea and palpitation. We always focus on that. And then along those lines, also, you should also always think of, aortic dissection. You should also be thinking about pulmonary embolism, although this is not just the only presentation, because they could also have shortness of breath or maybe chest pain. But in the grand scheme of things, I would categorize palpitation as cardiac and non-cardiac. So when I think of non-cardiac, I also think of endocrine disorders. So when I see someone having palpitation, I always think, is this patient having signs of hyperthyroidism as presenting with just a palpitation tachycardia? Is this a patient who probably is a diabetic and maybe he took his insulin without food and became hypoglycemic? Or is this patient who also having not only palpitation but also hypertension and is developing what is from an underlying pheochromocytoma? So those are from an endocrine disorders, but we should always think of medications. I am always, when I think of any symptom or sign, I have the back of in my mind about medications, what we give them and what we take away from them. So, elderly patient is not obviously an elderly. Any, things I would be looking for is this patient on an anticholinergic. So, or this patient on sympathomimetic. So I always think of those two as being reason. Regardless of their age, you should always think of injections. Is this patient maybe high on cocaine, PCP, and all those? Or could this patient be an alcoholic who actually is withdrawing from an alcohol? So I always think in that regard. But the other thing, like you stated, as a non-cardiac would be anxiety and so forth. So I think this is the framework that I have, and based on what I find further, then I would delve in further.
Awesome, thank you. So we're going to move on to the next outquat. One thing that I would add to the differential here, starting with the vomiting, would be just a viral gastroenteritis producing subsequent electrolyte abnormalities. Super common. I've forgotten about viral gastroenteritis as a possible differential for abdominal pain, diarrhea, and vomiting. So many times I can't count. And yet it's probably one of the few things on differentials that I would propose to an attending that I've actually experienced myself. And so I would just include that as a common things are common. Totally could be something causing similar symptoms.
I think in that regard, it's more the hypovolemia related. So it's kind of an indirect response. So the first response for hypovolemia is tachycardia. The next is orthostatic hypotension, and then shock. That's how I would phrase it. And obviously, like you said, electrolyte abnormalities.
Mm-hmm. So, all right, so we're going to move on with the case. I'm going to give you just a little bit more of the history for this patient, and then we're going to do just a tad bit of the exam. So, as far as past medical history goes, AFib is in the past medical history, status post cardioversion 1 month prior, diabetes type 2, hypertension and major depressive disorder. Recently was hospitalized for a urethroplasty procedure and was discharged 6 days prior to admission. Medications, is on multiple medications for the different disease conditions, and amlodipine, apixaban, bupropion for the major depressive disorder, hydralazine, metformin, dapagliflozin, hydrochlorothiazide, and metoprolol. Former smoker, quit over 30 years ago. So then we come to the exam. And so I'm only going to give us the notables from the exam, just kind of to spare some time. If there's some other information that you would like to know about, you can ask it and then I can supply it. So of note, blood pressure in the ED was 164/71. Heart rate was 62, not currently experiencing palpitations. Respiratory rate was 16, satting 97%, temperature 98.1 degrees Fahrenheit, afebrile. Had moist mucous membranes, no arrhythmias, heart was regular, rate and rhythm, normal respiratory effort. There was hematuria, but an indwelling Foley was present remaining from the urethroplasty, and it did have good urine output. And then neurologically, our patient was oriented to their person, place, and time, no neurologic deficits. And then Brandon, do we want to do labs here also, or carry that for the next portion?
Yeah, let's go ahead and throw labs in.
Okay, so John, I'm going to give you some labs. Again, I will give the ones that were pertinent to the case presentation and leave out some of the filler. So our hemoglobin was 16.7, which is elevated. Our white blood cell count was 11.7, which is elevated. Sodium was a little bit low at 134. Potassium at 4.1. Chloride, 91. CO2 was low at 18. Glucose was elevated to 134. BUN, 30. Creatinine was elevated to 1.13. Urinalysis showed protein, glucose, ketones, and blood. And then there was lactic acidosis to 2.2. Okay, so the next question, and I think Rachel will throw this one back at you as well. Next steps or treatment workup that you would like to do?
Yeah. So definitely need to get that EKG. I feel like in a normal ED, that would be, already attached and done by the time anybody's even really seeing them. But so want to get those results. I'm getting concerned. Definitely the first thing that catches my eye in this case is I'm getting concerned about that UA with ketones in the urine, especially when we're thinking about diabetes and potential for kidney disease that's messing with some of these electrolytes. Also that elevated white blood cell count, we'd want to start considering if there's some infection, maybe from that indwelling catheter that's been left in since his surgery. So probably get reflex that UA to a culture to see if we can find what this infection's from.
Brianna, what are you thinking about at this time?
I definitely agree with Rachel. I want to see I want to see that EKG. That's my first thing. I'm actually rotating in the emergency department right now, so that's what I want to see right now. I'm reassured that most of his electrolytes overall look pretty good. With his recent urological procedure, I would want to look back quickly and see what his baseline creatinine was. Excuse my dog. You know, after his surgery, his procedure, because depending on the patient, a creatinine of 1.13 could be normal or it could be elevated. You know, you could see, especially with elderly patients, it's easy to see a creatinine around 1 and be like, oh, that's normal. But, you know, if it's an small old person that doesn't have much muscle mass, that could be a doubling of their baseline. So I would want to look back and check that. I know Rachel mentioned the concern for just like diabetes with glucose in the blood, or sorry, in the urine, lots of stuff in the urine actually. That is, you know, it's lower on my differential at this point, you know, like a DK or something like that, just because that glucose isn't that high, especially in a type 2. With type 1s, it doesn't take a whole lot to send them into like a DK picture, even just as low as 200 can go there. With type 2s, to get serious glucose related issues, it takes typically a lot more for the general case. So right now, I think I agree with Rachel. I really want that EKG, and then go from there.
Okay, so I'll give you the EKG. Normal sinus rhythm, normal access, normal intervals, no hypertrophy, no ST elevation, no concerning features. Dr. Abebe, where would you go from here?
I think I would say I'm reassured by the vitals. For someone who presented with vomiting and palpitation, I would have expected the patient to be a little bit more tachycardic and maybe hypovolemic, especially given the fact that patient has, let me calculate the anion gap here, 819, 10. So definitely has anion gap. So when someone has anion gap and has a very mild lactate, I always want to find out if there is any other reason for the gap to be high. In knowing that the patient is diabetic and patient has ketones, I'm going to think of whether this is because the patient hasn't eaten and has starvation ketosis, or is this because, and I have said earlier, and I always say this to the students, when someone is on medication, I always look at the medication. So the two that actually stand out for me are metformin and dapagliflozin. And I also look at the hydrochlorothiazide. And I'm surprised the patient is on both combinations. Although I have little knowledge yet about use of dapagliflozin, it's an SGL2 inhibitor. And what it does is, you know, it inhibits reabsorption of glucose, which is normally absorbed majority of the time in the proximal tubules. So what it does is it acts as a solute to excrete so much fluid and makes the patient dehydrated. So usually that in combination with hydrochlorothiazide is not recommended. So if you see someone on dapagliflozin and hydrochlorothiazide, try to get rid of one, which I believe in this case, probably get an alternative for the hydrochlorothiazide. So I would say maybe getting rid of the hydrochlorothiazide would be the best way to go. So going back to the discussion, knowing this patient being on metformin, dapagliflozin, is this a phenomena of where the patient is having euglycemic DKA because, you know, the lactic acidosis doesn't seem to be significant enough for the patient, and the blood glucose is was 134. So that's something that comes to my mind. Is this because patient hasn't eaten and he has taken his diabetic medication and is starving enough to cause him to go into starvation ketosis, versus patient having a euglycemic DKA, which is a rare complication of dapagliflozin. But the fact that patient is on hydrochlorothiazide and the fact that you have osmotic diuresis related to the dapagliflozin makes the patient dehydrated enough to cause him ketosis. And I think, urine ketone would not, detect beta hydroxybutyrate. So I would like to get the beta hydroxybutyrate the test on the serum. I think that's what I would do for now, and get, if this patient was severely acidotic, I would get a blood gas, an arterial blood gas, but at least in order to get at least the pH, which you would need in this instance, I would get a venous blood gas. So those are the two things I would probably do. And I would comment on the white count. I haven't heard anything that would localize the infection. If anything, it could be a gastrointestinal infection. So you could have leukocytosis from a gastrointestinal source, or it could be a urinary tract infection because he doesn't have any respiratory symptoms. And from what I understand, he doesn't have urinary symptoms. So this is a question where, does he just have an asymptomatic bacteria, even if he had the urinalysis did not show, from what I understand, any pyuria, from what I understand. So UTI is out of the picture here. So if anything, the leukocytosis could be reactive versus a gastrointestinal infection. And I think I would say he's also hemoconcentrated. The hemoglobin is 16.7. And as Brianna has beautifully stated, I wouldn't be too comfortable saying the creatinine is normal without knowing where the patient's weight is. And I'm sure that dapagliflozin, one of the things it does is it actually decreases weight in the long term. So this patient may be in a state of what we call sarcopenia, where he doesn't have enough muscles. So I guess that's what I have in my thought process for now.
Awesome. Thank you, Dr. Abebe.
Can I interject real quick?
Mm-hmm.
Just looking at, reflecting on some of what I said after Dr. Abebe gave his wonderful reflection there, just doing some kind of cognitive biopsy on myself here. I did the classic mistake of looking at the electrolytes and saying, oh, those are all pretty normal, without calculating the anion gap. And that's really easy to get. You can have all, like, your sodium, chloride, and bicarb can be technically in the normal range based on what the lab says, and you can still have a big anion gap. And so that's, I'm typically pretty good about always calculating. I'm gonna give the totally unreasoned excuse that I was distracted by typing to scribe, but I didn't even calculate it. And so that was a key thing, and especially in this patient where we got a lactate that, yeah, it's a little elevated, but it's not elevated enough to explain that anion gap. And so that tells us we need to look for something else. There's something else causing that gap. And then we see our clue of the ketones in the blood, which would put us more down the path, like Dr. Abebe was saying.
Awesome. Thank you. So Rachel, you're going to be up next to update our differential. But in the meantime, while we're having this discussion in the ED, they happened to whisk the patient off to CT to get a CT of the abdomen. And they also managed to grab a couple point of care BBGs and beta hydroxybutyrates. Those are running on the machines right now. The CT results just come back concerning for mild bilateral pyelonephritis, which is concerning given the recent urologic procedure. So Rachel, in light of that and the impending labs, I'd like for you to update our differential briefly before we get those labs back.
So I think we can definitely be less concerned about a cardiac arrhythmia considering the normal EKG. Still would want to keep probably anxiety on the list, but push it way down. Viral GI still, considering what Dr. Abebe said, that could be still there. So leave both of those two things on there, but definitely higher on my list, considering this euglycemic DKA that Dr. Abebe described in a setting of potential dehydration and not eating, along with some stress, extra stress on the body from this procedure, and continuing meds. Also consider, like you said, other causes of high anion gap. So go through your mud piles, pneumonic, match up any of those, see if anything seems like it could be applied in this case. Looking at the smoking history and the low sodium, I'm just going to throw it out there, like an SIADH from a lung cancer. Yeah, I think
awesome.
kind of the things that I've thought about.
Sweet. Thank you very much. With the white count, I'd add infection/sepsis, question mark, even though we're not meeting the SIRS criteria, but we would have a source, and we do have some CT findings that are concerning. Rachel, I really appreciate how you kept a broad differential there, including things like other causes of anion gap acidosis. So we have a couple of labs. Point of cares just got back. The staff came walking over, and there is a little bit of a pH acidosis to 7.31. PO2 is low at 27, and the beta hydroxybutyrate is 8, which is elevated. Okay, so, okay, I thought Rachel was frozen, so I was wondering if I was frozen. So with that new information, what direction are we going to go for treatment? Let's update our problem representation. Brandon, I'll have you give a stab at that, and then we will start a direction for our management.
Yeah, so real quick practical tip here that I learned recently is that when you order like ketones, like blood ketones, urine ketones, beta hydroxybutyrate is not always included on that, and so you do have to order it as a separate thing. So I learned that the other day. So just a little practical tip there, because beta hydroxybutyrate is the main ketone in DKA. But so for the problem representation, to update that, I would say this is a 64-year-old male presenting with palpitations. I would say a 64-year-old male with type 2 diabetes on an SGLT2 inhibitor, presenting with palpitations. You caught me off guard there, Ben.
Give a shot at it, and then we're going to have Dr. Abebe revise it.
Yeah. I'm going to need his expertise here to fix my shortcomings here. On an SGLT2 inhibitor, presenting with palpitations, found to have glucose and ketones in his urine with an anion gap of 25.
Great. Dr. Abebe, how would you crystallize our problem representation?
I think I am not going to go far from what was just discussed that Google did, and I think what I would say is 64-year-old with type 2 diabetes on SGLT2 inhibitor, presenting with nausea, vomiting, palpitation, found to have slight hyperglycemia, ketonemia, anion gap metabolic acidosis. I think this kind of encompasses what our focus should be. I mean, we can kind of go in the anion gap kind of encompasses a lot of the things, and the presence of ketones and the process of ketonemia will be represented as well. So
awesome, thank you. All right, so we're going to move into the initial management, and we're kind of going to work through this middle tab here just a little bit. So I'll go ahead and start on the dispo, and then we'll kind of jump actually a little bit down to the interventions and the treatment, and then we'll come back and then address some of the further workup for what we need to do. Rachel, I'm going to shoot the interventions to you. Brian, I'm going to shoot the further workup to you, and then Dr. Abebe, we'll have you kind of summarize and wrap up. So as far as the dispo goes, you really have three questions. One is, do I admit this patient or not? And so that's essentially a decision between inpatient and outpatient care. This gentleman showed up at the ED with concerning palpitations, subsequently found to have acidosis, ketonemia, and some concerning features. And so when we look at him here, one, by coming to the ED, he indicated that he was concerned enough to come. Two, we found some signs that indicate that he is very likely in DKA and would warrant some inpatient admission. And so that's our first question: inpatient, outpatient, inpatient. The next question is, does this gentleman go to the floor or does he go to the ICU? And this is really a question of severity. Does he need ICU level interventions, or do we feel like we can better utilize resources preserving the ICU bed for another patient who might have more severe needs? And in this gentleman's condition, I'm going to make the decision that we're going to treat him inpatient, and we're going to treat him on the floor, not with an ICU status. And so I think that's indicated for a couple reasons. His heart rate is in the normal range. He does have an elevated blood pressure. His acidosis is not that bad. It's over 7.3. So yes, he's acidotic, but he's not supremely acidotic. He doesn't have Kussmaul respirations. His bicarb on his blood gas is almost normal. It's not nearly as depressed as you might see it. And then as far as his electrolytes go, they're close to approximation with the normal EKG. I'm not worried about some of the problems with hyperkalemia you can develop. And so I think he's all in all a fairly stable DKA patient. And so we're going to put him on the floor. And that's where I'd go for that. And now, Rachel, I'll pass it over to you for interventions that you'd like to do first for a DKA patient.
So I think there's like kind of 3 major pillars that you want to evaluate for a DKA patient. You want to look at their fluid status, so evaluate for that. Right now, I mean, his blood pressure is doing well. I'm not concerned for any sort of cardiogenic or hemodynamic instability, but his kidneys might be, depending on his previous creatinines, his kidneys might be thirsty a little bit, so consider giving some fluids. And then definitely the other interventions that we're going to do are going to continue to mess with their electrolyte status, so we want to continue to monitor that. So we're going to need insulin, because that's the big thing going on here, is we need to, you know, get this glucose and not have the body think that it's in a starved state. So you want to give insulin, but since you're giving insulin, you want to definitely watch that potassium number. So because of where his potassium is right now, he falls where you should already start wanting to give potassium and not just watch it, because the minute you give the insulin, you're going to be pushing that potassium into the cells, and don't want to get in a situation where you have low potassium and then cause a cardiac arrhythmia. So potassium, insulin, fluids. I don't think there's any need for bicarb at this point.
Awesome, thank you. The only thing I would add to that would be with his current glucose, I would add in a touch of D5 or D10 with his fluids to prevent from going into hypoglycemia. Great job, Rachel, on that. You thought through like all of the core features on it. Brianna, what's the further workup that you want?
Yeah, so Rachel, totally agree. That was awesome. Totally right on that. So as far as further workup, so the SGLT2 inhibitor induced euglycemic DKA is a fairly new understanding that we have, and we don't fully understand the mechanisms for it. There's actually a really awesome podcast about this on one of my many favorite podcasts, NephJC, which they basically just talk about new journal articles in nephrology. And they talked about a lot of different theories and thoughts about how this could happen, but we really don't understand how or why. So as far as further workup, I feel like this is a case where we don't have good markers to be able to, definitively diagnose and say this is for sure what was happening. But we can take the approach of test by treat. So in his case, I would definitely discontinue the SGLT2 inhibitor. With him being admitted, that's not necessarily a problem because we don't have that on formulary at the hospital. So he's not going to be getting it in the hospital, but just especially, if he's on, the floor, we just would want to make sure that that gets translated to if we change management, if a different team takes over, different attending takes over, that we cannot reinitiate this SGLT2 inhibitor on discharge. So I really do feel like that's most of what we can do. I also would want to put him on telemetry status. That can be done while there's also on floor status. They don't have to be ICU status for that. Just to make sure that this wasn't anything to do with his heart because he has AFib. I'd be wanting to make sure also before we, blast him with fluids that we are aware of what his heart's doing. If he's got a history of heart disease and stuff, want to make sure that He's not in heart failure because giving him a bunch of fluids could totally exacerbate the picture. So in general, I would want like a BMP every 4 hours just to watch his electrolytes, again, to make sure there's not something else going on. I really think that the test to treat is the best workup kind of at this point, make sure that he has good outpatient follow-up.
Dr. Abebe.
I think you guys did such an awesome job. I don't have a whole lot to add. I think when we think of DKA, fluid number 1, fluid number 2, fluid number 3, fluid number 4, fluid number 5, then insulin. I think I see a lot of times where we rush to give insulin. Remember, these patients are anywhere, depending on what you read and what you hear, anywhere from 6 liters to 10 liters. So the average, I would say, is maybe 8 liters. So remember, these patients are so dehydrated. The first thing that you should do is give them at least a liter of the fluid right off the bat. Sometimes you go into the ER or somewhere and you see the patient is getting 125 an hour. No, you give them a liter the first hour, and then you go ahead and start 500 ml an hour of normal saline. I know you probably heard this, discussion about how surgeons have been outsmarting us when it comes to fluid management. That Ringer's lactate is the medication. I would rather say the fluid that you would like to give and the fluid of choice. But in DKA, I would still stick with normal saline. I don't want to go to on why. There is a nice podcast if you want to hear about on Neph Madness somewhere. Brianna kind of talked about them. I really love them. So they come up with a whole lot of, but either way, give normal saline a liter, start 500 ml an hour, and then, like you stated, you can think of the insulin. Remember, the blood glucose matters. So if the patient is already below 200 in the case of DKA, I usually remember 200 and 300. 200 in the case of DKA, 300 in the case of hyperosmolar state, because the hypoglycemia is much more prone in patients who have DKA if you go beyond less than 200. So what you do is give them D5 normal saline when they are below 200. The reason is you don't want to give them too much free water and then get one of the complications where they develop cerebral edema, because you're pumping them with a lot of fluid. And then when it comes to insulin, you give them a bolus. I think it's like 0.1 unit per kg, as a bolus, and then you do the same thing, 0.1 units per kg drip, and then kind of follow the blood glucose every hour. And then electrolytes, depending on what you read and what people do. Some will do it every 2 hours, some will do every 4 hours. For me, I would like to give it time so long as I feel comfortable. So I do it every 4 hours. It's just like mind-boggling. And then remember, the other thing is it depends on the severity of children in this time. Okay, so it depends on the severity of the DKA. So if the patient is severely acidotic, then the patient is already in the ICU. Maybe they are still in cardiogenic shock. The fluid management would completely be different. And the same way with the insulin management, because you have to stabilize them hemodynamically before you move on with their insulin management. Obviously, then you look at the blood glucose every hour. And when you consistently say that their blood glucose is between, let's say, 150 to 200, but their gap hasn't closed. And one thing, I'm sure maybe I'm jumping off the gun, we base our treatment on gap closure and not necessarily the blood glucose going down, if you will, or ketone. Like you don't monitor the ketone to actually treat the patient with insulin drip. So when their blood glucose is between 150 and 200, some would say give them, like, decrease the rate by maybe to 0.05 or something, maybe 0.02, depending on how you feel, and kind of monitor the blood glucose. The other thing is you hear about bicarb, and this has also something to do in general about acidosis. The only time you want to give a patient who's anangab a bicarb is when they have severe acidosis, meaning their pH is less than 6.7. There are very few circumstances where I have seen intensivists give bicarb for other reasons. So get it out of your head. No bicarb in regular situations. So you just give fluid and insulin. Electrolyte, the electrolyte management, potassium. I think Rachel raised this and Brianna raised this too. So I remember two numbers, 3.3 on one side and 5 point something. I forgot the actual number on the side, but it's something around
5.2.
5.2. So if you are above 5.2, you don't give potassium. If you are below 3.3, don't give insulin yet. Because what's going to happen is, because of the acidosis, what's going to happen is, potassium is going to get pumped out, and then you are going to trouble of arrhythmia because of hypokalemia. I had a patient in the VA who went into tachyarrhythmia because of just that. So remember that. So if you are in between 3.3 and 5.1, you can give insulin, but at the same time, you concurrently give potassium. It depends on how you want to do it. Maybe you can give 10 to 20 for every little. I have seen people doing it even 40. Other electrolytes, not so much. You watch out the phosphate, you watch out magnesium. Normally we don't give those, but as you can imagine, and as you are aware, if you have severe hypomagnesemia, no matter what you do, your potassium is not going to get better. Let's say this patient is alcoholic, and he's severely hypoglycemic, then you need to give them that. I think that's all I have, and I would definitely say no more SGL2 inhibitor for this patient, and no more concurrent use of hydrocortisone SGLT2 for this patient.
Hey, Dr. Abebe, I had one question I wanted to add. So when you're, like, from a practical standpoint, for people who haven't seen like potassium replaced, how would you replace it in this standpoint? Would you add it in IV fluids? Would you give it oral?
So remember, we always talk about this. So unless you have, there are new rules actually in the pharmacy world. You don't give peripheral potassium more than 10 every 2 hours. So can you imagine how much you can give on a peripheral IV by just giving 10 every 2 hours? So the best management, unless patient has incessant and intractable nausea and vomiting, is to give oral. But if you have a central line, you can give 10 an hour. So you can imagine how late you can be in catching up in giving them potassium. So if you can, give them potassium. So let's say patient came up with a potassium of 3.5. I'll right out there, give them 60 oral, and then repeat in 4 hours. And this is while you're also concurrently giving IV potassium with the fluid that you're giving. So you are actually concurrently, because the whole point is, when you're giving insulin, when you're giving fluid, potassium is going to get shifted back, and you're going to, your potassium is going to re-equilibrate.
Awesome.
Does that answer your question? Sorry.
Absolutely, yeah. I think it's one of those things that it's kind of hard to visualize at times if you haven't seen it replaced. And so you think, oh, we'll just put it in their fluids, because that's kind of what it makes sense when you're giving them so much. But that's something that I learned in my third year. So
the way I see it as actually is, the one you're giving it through the IV fluid is kind of a maintenance potassium. The one you're actually replacing orally or additionally is what you think is the deficit. So they would have a pseudo hyperkalemia, and then when you start giving them insulin, what's going to happen is that potassium is going to get back, and when you treat their acidemia, they actually get hypokalemic. So you're kind of preemptively trying to boost their potassium store.
That's awesome. Thank you all. So I'm going to summarize our treatment plan, and then we're going to go to the clinical course, see what happened with this patient, and then discuss what we do once the DKA begins to resolve. So treatment: fluids. In the meantime, you check your potassium. If it's above 3.3, you start insulin. That can either be drip or it can be bolus. You're probably going to end up on a drip. And then depending on levels, you replete potassium, glucose, and then if needed, mag-phos, although that's going to be more rare. And you watch the gap with BMPs until it closes. So there's your one-liner summary of that. So we're gonna watch the gap on our patient, and I'm gonna give you just a little bit of their clinical course. So while they're in the ED, they got 2 liters of LR. They did not listen to Dr. Abebe's brief lecture on normal saline versus LR, starting around 5 p.m. And then they started getting some boluses of insulin aspart around 10 p.m. that night. And then regular insulin was started overnight through a drip. So the gap at 10 p.m. was 22. It had already started to close from presentation with the fluids. And then once the insulin got administered, the gap, and these are in 2-hour increments, BMPs every 2 hours, went from 22 to 18 to 15 to 11 to 7. And then the final one that was rechecked was at 11. And so as they were monitoring the gap, they monitored it every 2 hours with the BMP until it closed, closing at 4 a.m. that morning. And then they kept it on until 6 o'clock. And then at 6 o'clock, whenever the gap closed, they discontinued they continued the insulin drip, but they started a subcutaneous insulin to transition the patient. And then at 10 o'clock, whenever the gap remained close to 11, discontinued the insulin drip and started the patient on maintenance subcutaneous insulin, long-acting, with basal bolus. And so around that time, the patient began to eat and to tolerate foods by themselves, and really began to resolve out of DKA about 12 to 18 hours after they'd come to the hospital. Our decision to not put them in the ICU was well warranted with this, as it was a pretty good clinical sign that they had improved rapidly just with normal treatment. And so just a couple of questions from this. Why do we monitor to make sure the gap closes? And then why keep the insulin drip going once we start the subcutaneous insulin after the gap is closed? Either Rachel or Brianna would love to hear your thoughts on those two questions.
Rachel, let's hear you first.
Okay. So in regards to watching the gap closure rather than the glucose, I mean, I think this case gives a pretty good example of the glucose can look normal and you're still having an issue with the anion gap. And so I think that's more related to the pathology that is actually going on in this patient, is that you have this acidosis, you have the ketones that are being produced because of the starved state that the body thinks it's in. So the insulin is trying to treat that starved state and the effects of that starved state rather than just a glucose level, which in any person can, super high glucoses can, but in a person could be relatively arbitrary, and the gap is more important and the key thing that's related to the pathology more.
Yeah, totally agree with that. I think the gap is what is actually causing a lot of the metabolic abnormalities to happen. And as you have the insulin going, keep in mind that one of the receptors that the insulin works on is the hydrogen potassium pump. That's why the potassium gets so wonky with the insulin. And so as we are treating, that's what is really measuring the one-step effects of what our treatment is, which is the insulin. And so that really is the best measure. And the other thing that I just wanted to mention is that one of the electrolytes, there's a reason why we want to monitor them so carefully and be really careful, knowing that normal is not necessarily good in these situations. Because if you start out with a patient with, a sodium of 120 or a potassium of 7 or, a glucose of 500, if you dramatically correct those electrolyte levels to quote unquote normal, that can kill your patient. And so, making sure, and like all of those, the rates, I don't think it's worth necessarily memorizing, you want to change sodium by this much an hour and glucose by this much an hour. That's super easy to find online. Being in medicine isn't about how much you can shove into your brain. It's about how well you can use your resources and take care of your patient. So, look up those rates, use your pharmacists. They're absolutely amazing. And they are really good with math, whereas a lot of us aren't. So they're great. And just being careful to make sure that you're just taking this patient step by step, one step at a time, and not trying to like leap down the staircase, which can cause a lot more harm than good. Ben, I realized I kind of forgot what your initial question was, so I don't know if I even answered anything at all, but that's what was in my head.
You guys answered the first question really well, which was why to monitor the gap. The second question about why do you have a delay in the bridging between insulin drip being on while you start the subcutaneous insulin and give the first dose of that? That was a question that has not yet been satisfactorily answered.
Okay.
That's the easier one. Go for it, Dr. Abebe.
Oh, sorry. I was just going to say, I'll say I don't know first because I don't know
Yay!
that
Award.
question.
I think one thing you have to remember is the moment you turn off the insulin IV, the effect of insulin is almost gone. So you have to, you kind of have to give a buffer time for the insulin that you're gonna administer sub-Q to start working before you stop the IV insulin. So what you do is, in most circumstances, it's between 2 to 4 hours. I've seen even some people doing it within 1 hour. I think that's too close for me. I would do anywhere between 2 and 4 hours. So if you're planning, we used to be very rigid. We would say, keep the insulin drip until 10 p.m. And then, I would rather say, until midnight, give the insulin sub-Q at 10 p.m. You should not be very rigid on when you're going to do it. So long as you're sure that the gap has closed, give a buffer of 2 to 4 hours of your sub-Q insulin to take effect. I think that's the meat of it.
Awesome. Thank you. That's very helpful. All right. So we are nearing the end of time. There's a couple of quick hitting points wanted to knock out. And then I have one final question to ask before we do a wrap up. So in regards to that bicarb question we talked about earlier, some of the evidence would point that if pH is greater than 6.9, bicarb doesn't have a benefit and can be harmful. It would somewhat indicate that less than 6.9 bicarb could be helpful in correcting pH. At that point, you're going to be in an ICU. And so the moral of the story for our discussion is if you're seeing a DKA patient on the floor, bicarb is most likely not going to be indicated. If you're in the ICU, you can start to entertain it if your pH is severely acidotic, less than 6.9. And then one other tidbit point, a fun activity to do for a clinical condition is to see what people have treated it with in the past. So while preparing this case, went to PubMed, typed in management of diabetic ketoacidosis, and then you can filter PubMed by year. And so I went to the first 5 to 10 years that they had articles available. So I drummed up this really great article from 1947. It's called Salt Depletion, Peripheral Vascular Collapse in the Treatment of Diabetic Acidosis. A couple of things that were of note from it. One, they thought that high glucose was the problem. Another, they recognized that ketones were in the blood and in the urine, but had not yet realized that that was the cause of the acidosis that was causing all the problems. Thus the name of it as diabetic acidosis at that time. And then the other is that they'd identified that fluids were really the answer to patient outcomes improving, but they thought that it was transfusions and colloid products at the time, not saline. Even though they were starting to get that course with the salt depletion, kind of where we're at with the normal saline, they thought that the salt being low was the problem and that the lack of blood was the problem, not merely the fluid. So in a lot of ways in this article, they were right on the same page in regards to insulin treatment early, fluid administration early. But we have learned just a little bit in the time since about what actually causes it and what good treatment is. So the last question, this gentleman had been on his SGLT2 inhibitor for about 2 years. Why did he develop DKA now? Rachel, you take the first stab and then we'll go with Dr. Abebe and then we'll do a wrap up.
My initial thought would that it would be due to some sort of the acute stress that's happening due to his surgery. yeah, adding to, cortisol levels up, that sort of thing. I know those all kind of interplay with each other. That would be my first guess, but can't give you, an exact pathophysiologic answer.
I don't know is a good answer here because the truth is none of us actually know. We all have theories. Dr. Abebe.
I think I would go back to the pathophysiology of how dapagliflozin work, or the SGL2 inhibitors. The other one is empagliflozin. You inhibit the glucose reabsorption, sodium goes there, so you actually practically dehydrating this patient, and you add hydrochlorothiazide to it, and you're making the patient so dehydrated that you go into DKA. This is probably what really happened on this patient, because I can't think of any other reason for that to happen, because we have a patient who has improved without any antibiotic, which tells me that this is all a reactive process rather than a true infection. So talking about DKA in general, one thing we didn't talk about is we always want to look at what the precipitating reason for patients to go in DKA. Is it because they forgot their insulin? They didn't take enough? Do they have infection? Are they also alcoholics? Or do they have a major cardiovascular event? I will tell you, I had a patient who had a massive heart attack, and his electrolyte abnormality was so crazy. He went into DKA. So that happens for real. And the same thing with CVA, although I can't say I have seen a patient with CVA. So, he doesn't have any of the common precipitating reasons. So the one thing that I would focus on this patient is probably the fact that he is dehydrated, and primarily because he was also on hydrochlorothiazide. Another thing, just out of fact, dapagliflozin, because it causes glycosuria, patient can get a Candida infection, and that was something that I thought maybe he has a pyelonephritis, but usually it's very unusual to get a Candida-related urinary tract infection without truly having, candiduria from, I'd rather say candidemia, if you will. So.
Yeah, I was going to ask about the CT abdomen with the findings that were concerning for bilateral pyelo. Was that possibly a cause, and would you have started antibiotics in this patient?
I think this is the problem. It's not a crystal ball. If I saw this patient and I saw that, I bet you I will definitely start, because in medicine, sometimes we do things and kind of wait for cultures and so forth, because, but you have to also remember, patient came in, nausea, vomiting, prostrated, so he looks like he's sick, but then you go into the vitals, it just doesn't correlate with his, with someone who is septic, so it just doesn't sit well as if he has an infection. But nobody's gonna fault you if starts an antibiotic primarily focused for UTI like ceftriaxone, as opposed to going into the big gun and causing other problems for the patient.
Yeah, and Kelsey, one piece of the puzzle that didn't get into this presentation, in the ER, they were able to compare the CT with the previous CT from directly post-op surgical, and then also prior, and he had some of these similar changes. And so it looked like pyelonephritis, but it also was just kind of some residual inflammation, inflammatory change that was unchanged from whenever he had been healthily discharged 6 days prior.
And I think one other thing I was going to say was, we always talk about asymptomatic bacteria when you treat it. This is a patient who had a procedure. So it's not wrong to think of infection, despite the data sometimes not giving you all you need. And that's why sometimes you go in the side of, you err in the side of caution and treat with an antibiotic like ceftriaxone.
Yeah. Awesome. Well, we are on the tail end of time, so I'll go ahead and do a wrap up of some of the key teaching points. These slides, or this slide will be available later on. So first off, treatment of DKA, fluids. You need the insulin, monitor the electrolytes. Secondly, whenever you see a BMP, you should default calculate the anion gap so you don't miss something. And then another one from here that I'd pull out would just kind of be like maybe that last point that just got added for a normal finding. You got to compare with the previous. Know the patient's baseline. That came up with the creatinine, came up with the heart rate and the palpitations, and came up with the imaging at the end.
All right. What a discussion. You guys are all amazing. That was so great. I learned so much. I'm going to have to go back and watch that probably 3 more times just to pick up on all the little pearls that were dropped. Thank you guys all for joining us. This will be up on the YouTube channel fairly quickly here. We have all of our past recordings on the website. You can also give us some feedback. We really want feedback, whether you're here with us live or if you're watching this on the YouTube channel. We want your feedback. Also, if you're not on our mailing list and you would like to join us live, you can drop your email on the website there. I'll put the website down in the video description on the YouTube channel, and then you can join the fun live. So thank you all for coming, and with that, I'll say goodnight.
All right, good night. Thank you for inviting us. Thanks.